even here?
Ivan Puglisi, 55, has experienced a day of abdominal cramps, vomiting, and diarrhea. Afebrile, tachy at 124, BP 192 over 100.
All right, so to recap at this point, we have Dr. Mohan and Whitaker seeing a 55-year-old male patient with abdominal cramps, vomiting, and diarrhea for, I think it was a day. Now, heart rate, he's tachycardic at 124. That's legit. We get a little bit excited about that. You know, we're hoping for something really good. 96% of room air, that's good. Blood pressure, high, 192 over 100. All right, so something's going on here. And again, tachycardic. So as an ER doc, the differential at this point is massive. We need the history. We need a detailed history, especially if we have not seen this patient before. So the more that you don't know, the more you need to ask. I've said that a few times. And we need a complete physical exam. So you can already start thinking in your head, just over a few seconds when you see this patient, is this cardiac? Is this GI? Is this infection? Is this sepsis? Is this dissection? Like the list goes on and on. It's massive at this point. We're utilizing that history and physical exam to help narrow this down.
I'm Dr. Mohan.
I'm student Dr. Whitaker.
Nice to meet you guys. I would have called my own doctor, but I'm from New York. You two kids ever been out there?
Oh, I've never been to New York. Coming to Pittsburgh was my first time leaving Nebraska.
All right, so my critique with this scene is Dr. Mohan doesn't even bother getting the history. She heard the brief story from the nurse, and she goes immediately to listening to the lungs. And I think they tried to set that up because Whitaker is going to be asking the questions. It's how they tried to do it. But interns and medical students watching, don't do this. Get your history first. Also, you know, he is talking and she's trying to listen to the lungs. Literally, the patient is talking and she's trying to listen. When a patient is talking, any good doctor that happens to be listening to the lungs, I can promise you this. Like if I'm, let's say I come up with another question I want to ask, but I'm already at the, the lung part of the exam. As soon as that patient starts talking, I have to take the stethoscope and lift it off the back, or if I'm listening in the front, I have to lift it off the chest because you can't hear anything. Like, you definitely can't hear them talking, but you can't hear the lungs. Like, you have to take this off the chest and you can still hear. But again, if you're gonna make it look realistic and you're gonna talk to that patient or listen, and you're listening to lungs, like you're gonna listen to the talk and you're gonna listen to lungs, like take this off the chest, take this off the back. That's what's realistic here. Again, very small detail, but I told you in this channel, I am picking out everything. Am I gonna miss a few things here and there just because of the level of detail? Absolutely. There's certain things I'm skipping because these videos just be hours and hours long. But I told you, I am going to nitpick for realism. I'm gonna nitpick for detail. We are hitting everything on the pit, all 15 episodes.
How long are you in town?
Just till Monday. My daughter's getting married. She's my baby and the only girl.
Congratulations.
Yeah, thanks. You know, they say you're not supposed to have a favorite kid, but
I'm an only child, so I was born the favorite. Whitaker?
Oh, youngest of 4. I'm just happy when my parents remember my name.
No, I meant, do you have any questions for the patient?
Oh,
hey, can I just get something for the pain, you think?
As soon as we're done with this assessment, we just want to do our due diligence.
any intestinal disease in your past? Ulcers, gallstones, general stomach ailments, surgeries?
No, nothing.
There she goes again, listening to the abdomen now. How about you ask your questions as well? Stop doing the physical exam that you're doing right now and get a history. Whitaker's doing a good job of asking questions, but there are a ton of things they didn't ask yet. So Mohan in this case just skipped directly to the physical exam, as I mentioned. Now, will an ER doc go right to the physical exam when seeing a patient? Sometimes, yes. But it depends on the situation. So let's say you have someone coming in on CPAP via EMS. They can't talk. They're literally guppy breathing. Respiratory distress is bad. They are in severe distress. Blood pressure is 60 to 70 systolic. Heart rate's 140. Respirations are up to 50. They're diaphoretic. They are minutes from death. You do your immediate heart and lung exam and you do a bedside ultrasound. They are in tamponade. They get an emergent bedside pericardiocentesis. After vitals stabilize, they're able to talk with you. You saved their life. Again, a different situation here. Obviously, you would not have sat there for 5 to 10 minutes asking the patient questions that was on that CPAP as they're guppy breathing. They can't talk. They're in that much distress. They need immediate treatment or they're going to die. So there's certain things that you're going to do before other things. In this case, in this patient, never been there before. They probably don't have any history. You want a detailed history and then a physical exam. So I will say on another note, it's a red flag when a patient asks for something for the pain before we've actually completed the history and physical exam. Patients often may think that we're immediately going to leave the room, like mid-history or mid-physical exam, put an order in for pain meds. The nurse is going to rapidly see that order, ignoring the rest of their patients. They're rapidly going to see that order. They're going to quickly get that medication, realizing, they have a lot of patients with a lot of meds. They think that the nurse is immediately going to see that order. They're immediately going to get the meds. The nurse is immediately going to come back and administer the medication right away. And then we're going to come back in the room and continue our exam. 100% not realistic. That's not how that works. We understand you're in pain, but we need to finish our questions. We need to finish our exam. Now, I will say there are times that we have to give medications first to get a better exam. Different situation. We have a patient comes in after a trauma. They did a lot of methamphetamine. Right now, they're in full on, they're tachycardic, blood pressure's high, they're having all these different symptoms. They're combative, aggressive. Maybe they had some PCP in there. We're trying to assess, because this is a trauma 1, multiple injuries, we're trying to assess them. But then at the same time, we can't because of how aggressive, combative. So sometimes it requires, and they're like thrashing and everything else. And so sometimes it requires medications so that then we can do our exam. And that has to do with kind of a safety thing. So again, there's a multitude of other reasons, but I'm specifically talking in this case about the Pitt, but specifically talking about this case. But overall though, just finish the history and physical exam. In this case, before you give meds. So I did like that they mentioned that they wanted to complete it before the meds. That was very good.
Good bowel sounds.
Thank you.
Abdomen soft. Nothing focal.
Anything else bothering you?
My back is killing me. 4-hour car ride will do it.
So when patients come to the ER for abdominal pain, we're going to listen with a stethoscope, but I'm going to let you in on a little secret. We're also going to palpate with a stethoscope, not just with our hands. So in patients with chronic abdominal pain or patients that have drug-seeking behavior, oftentimes what we're going to notice is that doing an abdominal exam via palpating with the hands does not give the same response as palpating with a stethoscope. All right, now obviously that's not the same for every patient. Classic example would be the one I had last week. Abdominal pain at 10 out of 10, actively eating corn chips, right? They come in, abdominal pain, doc, pain's at 10 out of 10, I can't handle it, worst pain of my life. Hold on, can you just come back? I need to finish my phone call and eat my corn chips at the same time. Oh, my pain's at 10. Actually, you know what? It's a 10 and a half. No, doc, it's 11 out of 10. Worst pain of my life. But come back, I need to finish the phone call. So you're doing this exam. Before you even push on their abdomen, oh, doc, it hurts. You're like, I haven't even pushed yet. And you were just eating corn chips. And your pain's, I don't understand what's going on. They're flinching, they're yelling right before you push. And then you take your stethoscope. They think that you're listening, when really, at that point, you're not listening. I'm pushing with this. And you start pushing with your stethoscope, and there's zero pain. They're still talking. They're eating corn chips while you're pushing with the stethoscope. We can actually push almost to the floor, if you will. Deep palpation with a stethoscope, and we elicit zero response. We're actually watching the facial expression during that palpation. So at that point, that's a benign exam for any acute emergent process. Like, we elicited zero response. And then you let the patient know that you're actually gonna, okay, I'm just gonna have a push just one more time. And then you just barely, oh, doc, it hurts. And it's like, they shouldn't change. An abdominal exam should not change like that. Pain should not change based on palpating with the hands and palpating with a stethoscope. You don't magically go from 10 out of 10 or 10 and a half out of 10 or 11 out of 10. First off, the scale only goes to 10. Like 10 is you get your arm cut off. 1 is like you stub your toe. That's the score. And so you don't magically go from a 10 out of 10 flinching prior to palpation to a 0 out of 10 talking to the provider when they're doing deep palpation. Again, you're not hurting them, you're just pushing. It's a deep palpation. You're trying to elicit something. One of the surgeons I work with, to get a good abdominal exam, he will always talk with the patient during the exam. I love that. So you don't have to palpate with this. You can also palpate while talking to the patient because you're distracting them, all right? The best exam that a medical student's gonna get, the best exam that a resident's gonna get is if you can get an authentic abdominal exam while you're distracting the patient. True abdominal pain will reveal itself. You want to get the most accurate exam possible, and true pain is not going to change with distracting that patient. It will hurt regardless. So again, medical students watching this, feel free to drop a comment if you've already encountered this situation or if you've used that technique as well. I love it. Again, this is different in all patients, but I want to be clear on that. This was just one example of palpating with hands and palpating with the stethoscope on the same patient. That exam should not change. With a true pain and true ER pathology, it's going to be the same both ways.
I mean, the last time I tweaked it, I think they gave me morphine, and that worked pretty good.
All right, so we've talked about how the abdominal exam should not change. Whether you're palpating with your hands, you're palpating while talking to them, you're palpating with the stethoscope, true abdominal pain, a true, really good abdominal exam shouldn't change one versus the other. It will be the same kind of across the board. Now in this case, the patient states tweaked it and they gave me morphine. So that is another red flag, and that you see them look at each other. So while he is really starting to give off drug-seeking vibes, the real reason I pause here is because I still caution, all right, I caution those that are watching this, she did the majority of the history after the physical exam, which is backwards in this case. Now the blood pressure is elevated because of pain, possibly, all right? Is he in opiate withdrawal? And that explains the vitals and the heart rate, maybe. But realize they still did not get a complete history on this patient. The patient had tremors and they were mildly diaphoretic. And already at this time, is this alcohol withdrawal? They can have a seizure in another few minutes. Is this opiate withdrawal? Now they do ask, if I recall, they ask about alcohol and things like that. And the patient stated no. They can kind of press this a little bit further and ask a little bit, have you ever drank alcohol? Well, yeah, occasionally I had some. Well, when you do occasionally have it, how much you drink? You get a patient sometimes that'll be like, well, I just drink a glass of wine. Turns out that glass of wine actually holds an entire bottle of wine. Now, I will say every patient that is drug seeking, will they say this? No. Will patients have a real emergency like an appendicitis that are also exhibiting drug-seeking behavior? Will they also say this? Absolutely. So just keep that in mind. Even those that are drug-seeking or appear drug-seeking can have real emergencies. Your frequent flyer with chest pain that visits multiple times a week. Be aware, one of those times could actually be a STEMI. One could be a pulmonary embolism. That frequent flyer with chronic pancreatitis, chronic abdominal pain, sooner or later is going to have something emergent. Let's say they keep getting recurrent pancreatitis and now they come in with severe abdominal pain, lactate 6, and they actually have a superior mesenteric vein thrombosis, celiac vein thrombosis, which are complications of that. So you got to keep this in your mind as an ER doc, and I think that is the benefit of a good residency program, is you're learning all these things and you're not skipping steps. So realize that even drug-seeking patients, even patients with chronic pain can have emergencies.
Do you smoke?
No.
Drink alcohol?
Once, twice a month. I'm not a big drinker.
Any recreational drugs, either pills or by injection? Tranquilizers, hallucinogens, painkillers?
All of the above. Yeah. I'm kidding. No drugs. Never.
And what do you spend your time doing?
I'm an actuary. It's risk management, stats. It's pretty much a desk job.
I pulled Zofran for the nausea.
Start with 4 repeat PRA.
What, and that's it?
For now, we're gonna start with some blood tests. We'll be back soon to check in on you.
All right, fine.
What do you think?
Big differential of pretty serious stuff to rule out.
So what's your plan?
Besides Zofran, CBC, CMP, IV fluids, morphine, maybe CT.
Good, Whitaker. Very good. Big differential. You may be thinking in the back of your head, drugs, alcohol withdrawal, but again, you still consider other things. That's why you get blood work and imaging. This is a patient new to the area, so likely you're not going to have access to his blood work, any imaging. Likely, if the patient's out of state, you're not going to be able to see those medical records, those medical charts. In some systems, you can actually see records from the surrounding hospitals. I can pull up a system. There's a way to look, okay, they were at this hospital and this hospital. I can see the labs, I can see the imaging. But in some systems, you can't see that. Now, you can ask the patient, which hospital they were just at, and you call that hospital. Ask to get put through to the ER and speak to an ER doc. You find out that the patient was there dozens of times. It's their frequent flyer at that hospital. And, the patient was just at that hospital 6 hours ago. And the patient told you, well, they didn't do anything for me. They didn't fix me at all. They didn't do anything for me. And it turns out they did blood work, they did imaging, right? They got a CBC, CMP. It was extensive workup, multiple troponins and EKG'd and CAT scanned the abdomen. Patient still had pain. They CAT scanned the chest, right? This massive extensive workup, and then found nothing. And then patient was ultimately discharged. Now, they did this extensive workup. They found nothing. They told the patient, follow up with the PCP. Well, he didn't want to follow up with the PCP. He wanted another opinion. Now, every doc is different. Things change. In the example I just gave you, we're seeing that patient 6 hours after the previous hospital saw that patient. Things change in 6 hours. So we'll call the ER, we'll see what they did, and sometimes it's good to actually have a reference, for example. So in this case, white count was 8 in this particular patient. Was seen in an outside hospital, right lower quadrant pain, CT was read as normal. It was an IV contrast study. You see that patient 6 hours later, still with right lower quadrant pain. That's pretty normal. What you're going to do at this point is, abdominal pain is not normal, but seeing that patient persistent pain is pretty normal to get blood work. So you do that. They had a white count that was normal, that was 8. Now the white count is 19. They still have right lower quadrant pain. In this case, gave a call to general surgery. They saw the patient. Turns out that CT, when you look at it, the appendix was the upper limit of normal. So likely now, we wouldn't repeat the CAT scan, in this situation, but likely if you were to repeat it, now you'd have some periappendiceal fat stranding. Now it would be more of your appendicitis. So patient was taken to the OR. Sure enough, this was an appendicitis. In this case, in the TV medical drama, you get labs. Let's say they're all normal. That's a different situation. So all of that to say, just consider the possibilities and make sure you do a detailed history and physical exam. Overall, great job to Whitaker for wanting blood work in this situation. 100% agree with it. Awesome job.
Good on labs and IV fluids, but no morphine. Treat his symptoms with clonidine and muscle relaxants.
What if he's... Look, I really can't lose another patient today.
Remember how I said you get good at spotting the fakers?
Yeah.
He's exhibiting every sign of opiate withdrawal.
Eyes dilated, tearing, skin has piloerection and goosebumps, hypertension, tachycardia.
Agitation, restlessness, perspiration. He's checking every box.
Right, but he said he doesn't take drugs and seldom drinks alcohol, so that's exactly what he would want you to believe if he was drug seeking. Wow, you're good.
Thanks. I am.
So how do we treat him?
By getting him to admit his opiate usage.
Right, how do we do that?
By being smarter than the patient.
Got it.
Now, he may be exhibiting every sign of opiate withdrawal, but again, I caution the situation. Now, they never mention EKG. I would add an EKG onto that. And the reason for that is nausea, vomiting, diarrhea. What happens, if the patient has a prolonged QTC, it's not uncommon to start getting deficiencies in potassium or magnesium in these situations. So what happens, the EKG shows a prolonged QTC, it's 540, 560, 570, 580, whatever it may be, and you give them a QT prolonging agent like Zofran. The patient actually goes into a lethal arrhythmia like Torsade. So again, I would probably add on a mag level to this. I would add a few additional labs on what he said. But overall, I thought it was good. I would just add a few things myself. Now, this is a different situation if you had someone present the same way, same vitals, but your abdominal exam was different. This was a patient that said the exact same thing. They gave me morphine last time for pain, but now you do your exam, and even with distraction, it stayed the same. Diffuse pain, even with the stethoscope. Now, something's going on here. So at that point, the patient may be in alcohol withdrawal, they may be in opiate withdrawal, but you don't want to miss the fact that that withdrawal patient now has a ruptured appendicitis. Realize patients can have more than one diagnosis. Even patients with chronic pain and those in withdrawal can have real pathology. So please keep that in mind, especially med students, future physicians, residents, anybody watching this. Realize you don't want to get narrow focused. You arrive at that first diagnosis, boom, drug seeking. And realize that patient alcohol withdrawal, they're actually having a STEMI at the same time they're in withdrawal. The patient in opiate withdrawal, they actually have a ruptured appendicitis. Patients can have multiple things going on at the same time. So I think one thing to at least carry away from this critique, you just don't want to focus on the very first diagnosis you come to and think that, that's all it could be, because you could miss something.
Because I feel worse. I told you that I got better last time with morphine.
I have a morphine-like drug called Bupe. Works the same way and faster, goes right under your tongue. If this doesn't work, we'll switch to morphine, but let's try this first, okay?
I just want the pain to stop.
Open up, lift your tongue, leave it there, and let it dissolve. We'll be back in 10 minutes.
Just so I'm clear, our plan is lying to patients?
I didn't lie. Bupe is a morphine-like drug, binds to the same receptor.
He said he isn't an addict, so why give him an opiate agonist to treat his withdrawal symptoms?
Because I don't believe him, and I know this will work. Then, once he feels better, we can get him to admit to his addiction and treat him long-term.
If you say so.
First, do no harm. Then do what's best for the patient.
So buprenorphine is a partial opiate agonist, meaning it does target opioid receptors in the brain, but to a lesser extent than that full opiate agonist like heroin or oxycodone, things like that. For starters in this case, residents don't just give these meds, nurses do. So already that's not realistic. I will critique this every time. Residents need to stop giving meds the nurses give. Nurses will have to chart what time it was given. Residents don't just give the meds, then go find the ER nurse and be like, hey, I gave the med at this time. That's not how this works. Like, why are we doing this? Pitt, why are you doing this? Everything needs documented. For another thing, like we talked about earlier, I would question doing all this without any labs, blood work, anything back. I would argue no good ER doctor or ER resident is going to administer this medication themselves without the nurse to a patient before blood work is back in a case like this. The resident hasn't even staffed the case yet with the attending. I said this in part 1, but I'm starting to gauge here that the physician behind this episode was potentially different than the previous episodes. I don't know if that's true, but there are just too many things in this episode that are not realistic, don't make sense, and are just overall, really it's heartbreaking.
I'm feeling a lot better. Nausea is gone.
What about your stomach aches, muscle cramps?
I mean, I'd say I'm 75% better.
Blood pressure and heart rate are back to normal.
Incredible.
You sound surprised.
Oh, no, I'm just relieved for you. So.
Good news is you can have another dose. That should get you back to 100%. Tongue up.
Drug seeking or not, I think overall how this case was portrayed was not good. And of course the resident is again administering the medication herself, which would not happen.
Hasn't admitted any opiate use.
No, but again, he exhibited every symptom and now he's 100% better.
And it feels like it was just a few hours ago. I was asking you, why didn't you consult me first, and specifically telling you never to do that again. But instead, you went behind my back and
I did it
you
again.
did it again, for fuck's sake. Is anybody honest about anything anymore?
She is just now staffing this case. I will say it's not uncommon for senior residents to, to not discuss or staff a case till later on, especially the 3rd and 4th year residents that are further along in the training. But it does depend on the case itself as well as the attending, the comfortability level. Plenty of times through training, we had docs. It didn't matter if you were a 1st year, a 2nd year, a 3rd year, or a 4th year resident, or a chief resident. It didn't matter. They wanted to know about the case immediately. It's just how some attendings are. So there's a lot that goes into that. But I was definitely expecting her to staff this much earlier on than she did, especially with what we've seen, of Dr. Mohan throughout the season, including slamming 3%, which was Santos as well, but Dr. Mohan went along with it as one of the senior residents, and she did it herself. Clearly, this is not the best 3rd year resident, and I would expect her to staff more cases with the attending earlier on. Now, if we're being honest here, if we're being completely honest, throughout the season, I've discussed the year in residency needs to match the experience level, and I would give her knowledge level to that maybe of a 2nd year EM resident, not a 3rd year EM resident. If the Pitt changes around the year of the residents, some of the things become more believable. Other things, not so much. I believe Dr. McKay is a 2nd year resident, if I recall. So far, she's one of the few, her and Langdon, where the actual year in residency corresponds to that degree of training. If you recall back to the canthotomy scene, and Dr. Robbie had her do the canthotomy, she acted like surprised that he was going to let her do it. I can tell you this, no 3rd year, no 4th year would have even questioned that. They wouldn't be surprised. They would have jumped right in. Heck, even 2nd years may have did that. And here she hesitated, but it was believable that she was a 2nd year, because remember, we're only a few months into 2nd year, so I totally believe that, all right? I told you all watching, I would critique down to the smallest detail of each episode.
That was rhetorical. Why didn't you come and find me?
You were a little busy.
Really? Do better, Dr. Mohan.
Yes, do better. What do your labs show? Did you rule out the emergent cause, or did you just jump to that he was, it was all chronic pain and withdrawal and he was drug seeking? You didn't get your attending because he was busy? That's not your call to make. Find us. Tell us you have a case to staff. Even if I'm in the middle of a resuscitation, resident comes in, it's like my own patient, I'm in the middle of a resuscitation, resident comes in to discuss a case. As long as they don't mention names, room number, etc., leaving the specifics out, they can discuss that case right there. That's pretty common. Let's say I have a COPD patient, COPD exacerbation, they're in hypoxic and hypercapnic respiratory failure. I'm getting ready to intubate them, I'm setting up, I have respiratory present, right? I have everybody present, ready to go. And so a intern or second year resident comes in the room because the patient they just saw, they want to staff with the attending first, maybe it's the first time in the year, whatever it may be. And they need something ordered and done immediately. In this case, it's a vaginal, this is a very specific example because this literally just happened. Vaginal bleeding, right lower quadrant pain, positive urine pregnancy at home. The concern is ectopic pregnancy. That's okay. Let's get the blood work, serum HCG, urine HCG, RH type screen, bedside ultrasound. Go ahead and get the ultrasound bedside. I'm going to be in there right after this. We're going to take a look with the bedside ultrasound, see if we see any free fluid, see if we see anything obvious, at least within that right fallopian tube. That is pretty normal. It's not the resident's call to make, oh, the attending looks busy. I'm going to do, nah, he's still busy. I'm going to do all the blood work myself. I'm not going to staff it to the very end. He just looks busy. That's not your call to make. That's not how that works, and a third year should know this. No third year resident, this gets back to what I just talked about where the degree of training doesn't correlate. No third year would say the attending looked too busy or you were too busy, so I figured they're not going to do that. Any third year in the country knows this, leading to the fact that Pitt may give her an R3 title, but really she is the knowledge level of an R2.
Yes, sir.
Using Butte was unconventional, and while it wasn't dangerous, it could be subject for scrutiny, which I really don't need any more of right now from Gloria. I expect a level of this from medical students. I expect more from an R3.
Exactly, way to tell her, Dr. Robbie. Residents don't just give that themselves to a patient in the ER. Dr. Robbie just tells us, she's a senior resident, she should know better. But then again, she did slam 3% earlier, so clearly the training in this residency program is not up to par, which is not on Dr. Robbie, as these residency programs have tons of faculty members and attending physicians that all teach. These programs have numerous faculty members. It's not just one person teaching, numerous faculty members for teaching. So maybe this is a residency where not all the ER attendings are good teachers and only a few are. Something like that would definitely have an effect on the program for sure.
Just give him to Cindy, have her hold him, and then you don't got to think about it. Because I'm your father, that's why. Listen, the doctors are back. I got to go. I'll talk to you later. Yes, I love you.
How are you feeling, Mr. Puglisi?
Oh, so much better, thank you. You guys think that I could have a little bit more of that medicine just for the few days that I'm out here? Just want to be able to walk my daughter down the aisle without shitting myself.
The medication we gave you wasn't morphine. It was something called buprenorphine, or bup.
Yeah, no, she said that. I mean, whatever you call it, Doc, it worked great.
It's a medicine specifically targeted to treat opioid withdrawal. That's why it worked.
Well, I don't understand.
All indicators are that you have been using opioids. That would include pain medication like hydrocodone, oxycodone.
I told them I don't do drugs. Wow. You lied to me.
I didn't lie. I said I was giving you a morphine-like drug that got rid of your cravings.
Wow. You know what? This is bullshit. I mean, I could sue. All of you hear me? I'm not some junkie on the street. Look. I got a family, I got a job, I make good money, I return my shopping carts, I pay my taxes. That sound like a drug addict to you?
Yes. Because anybody can be an addict. You were proof of that. These pills that you were taking, they're not helping you with your pain. They are keeping you stuck in it. A lot of really good people struggle with addiction. It is a brain disease, but social environment and personal choice are also factors.
I don't have a
problem.
problem.
The good news is that the brain is highly dynamic, as is the environment, but you need to stop now before the damage is irreparable.
No, screw this hospital, okay? And screw you.
Hey, Dr. Mohan will advise you on our proposed action plan. You can either choose to follow it or not. That is entirely up to you. I wish you luck, Mr. Puglisi.
We're giving you a 7-day supply of a drug called Suboxone. We can set you up with a medication.
Fuck off, I'm not interested.
My father passed away when I was young. I don't know if I'll ever get married, but if I do, it'll be without him walking me down the aisle. I'm glad your daughter has you there on her wedding day. I hope she gets to have you there for all of her other big days to come, too.
So side note here, the reason I paused is because I want to talk about patient satisfaction. We've heard about it briefly throughout the TV series. I haven't really commented on it too much, but we're going to kind of take a deep dive into that. Basically, hospitals have certain targets they want the physicians to hit, a certain percentage of overall patient satisfaction. Now, I want to talk briefly here and explain a few concepts that may be unfamiliar to non-medical individuals. And then if you are medical, we are going to have a moment of just pure truthfulness. And I'm also stating my opinion as well. All right, so patients that present to the ER are either discharged or admitted, or they elope or leave AMA. Basically, discharged or admitted. I'm just going to focus on that. They're going to get a satisfaction survey. Every hospital is going to have it differently. Some will actually call the patient and they'll have a survey that they do over the phone. So the question becomes, how does a typical ER, all right, or a typical hospital divide satisfaction between ER and inpatient? So when a patient's seen in the ER, you're going to have a satisfaction score to the ER doctor, and you're going to have a satisfaction score to the admitting team, all right, to the admitting doctor like the hospitalist, all right. This is where it gets interesting, and this is the part of patient satisfaction that frankly no ER doctor likes, all right. Typically all patients that are discharged from the hospital, that satisfaction score goes to the ER doctor. And the admitted patient, so the patient that you saw and got admitted, that score, that patient satisfaction goes to the admitting doctor. All right. Even if that admitting doctor didn't do much and you did all the resuscitation, you did all that stuff, it doesn't matter. You don't get it. They're admitted. All right. That score goes to them. You may be like, wait, Dr. Taylor, I don't think that's fair to the ER doctor. Aren't patients that get admitted in general sicker? You saved their life. Perhaps it was a cardiac arrest, a gunshot, a stabbing, meningitis, STEMI. Guess what? ER doctors don't get that score. The hospitalist actually gets that score. So let's say your ER has a 30% admit rate. That means 30% of your patients that come to the ER get admitted. All right, 70% go home. The patient that gets admitted, the surveys and satisfaction of those patients go to the hospitalist. What do we get in the ER? We get that 70% that go home. Will all 70% fill that out? No, absolutely not. So why is this an issue? It's cases like this, if patients don't get what they want, like Dilaudid instead of morphine, score of 0. Patients don't get the drug they want, score of 0. Patients with chronic pain for years, seeing multiple specialists, no answer. They come to the ER for their 3rd and 4th opinion, and they leave with no diagnosis. They give us a 0. Patient has a 9-hour wait time and later discharged. They get a 0. Coffee is cold and the patient did not get a blanket fast enough. Score is 0. The family never got the Sprite they wanted. Score is 0. Or that patient that takes the survey so seriously, they come in threatening their survey results at the beginning of their ER stay. This happens. That patient comes in and says, Doc, if you don't give me that Dilaudid, it always works for my chronic pain and I want my work note for 3 days. When they call me for my survey, I'm not giving you a 10. Or in the case the patient states, Doc, I can already tell you, if you don't find what's causing my pain for years, I'm not giving you a 10, I'm giving you a 0. And of course, that patient, you just ruled out every single emergent life-threatening condition. You did multiple labs and image. They came in with whatever it may be going on for years. You do this massive workup, labs and imaging and CAT scans. You do all this stuff. You even went out of your way to call even a few specialists to get them follow up. You even got them a PCP. You literally went above and beyond, but you ruled out every single emergent life-threatening condition. At that point, this is all routine follow-up. Guess what? That patient's probably going to give you a 0. Literally every life-threatening diagnosis you ruled out, they're going to get that phone call. They're going to give you a 0. Why? That doctor couldn't figure out what was going on with me. Well, we did. We figured out that it wasn't an emergency. All right. Do you know what score you get for all of these? Again, you get a 0. Maybe a 1. Maybe you get lucky. You get a 2. Doubtful you're getting a solid 10. And in some hospitals, they only actually look at certain numbers that benefit. So certain hospitals will take 8s, 9s, and 10s. or they'll take the lower, like you don't get the middle one. And so, they get thrown out. So overall, you start to see this score forming of these discharged patients. That patient that you admitted and saved their life, you don't get that score. That cardiac arrest you had that you got a pulse back, they went to the ICU, you don't get that score. That sweet grandpa with appendicitis that you talked about fishing with, you don't get that score. That 6-year-old you admitted for dehydration and the family raved about you, you don't get that score. That patient that you saw for this chest pain, it radiated to his back, you made the decision on a CT, they found a dissection on the CAT scan, you treated it, he got admitted, he went directly to the OR with cardiothoracic surgery, you saved his life, you don't get that score. The patient in this case is likely going to give you a 0. At the end of the day, did you die? No. The ER is a place for emergencies. The ER is a place that we rule out the emergent, life-threatening condition. If you walked out of the ER, that satisfaction should be 10. Sadly, as this TV series has shown, they have shed light on patient satisfaction and the stress it places on ER doctors every single day to try to alter their care to please management and to please patients. I hope you can start to see the issue with patient satisfaction scores. Enough of that soapbox. Let's continue.
Knock, knock.
To what do I owe this pleasure?
I found these. You must have dropped them. Gotta be more careful. You don't want these ending up in the wrong hands.
You can keep them.
You ever think about quitting?
I'm not a quitter.
Oh, I know. You're a happy drunk today. But one day, when your liver fails, and believe me, it will fail, you won't be so happy. It's not a nice way to go.
I'm digging my own grave. Let me.
I don't have to give you the shovel.
So you can explain to patients all you want, but at the end of the day, it's up to them to want to make that change. That COPD patient that wears 4 liters of oxygen and still smokes a pack a day, sometimes they're smart and they actually take off their oxygen while smoking, sometimes not, and they come in when it blows up in their face and I have to intubate them, put them on a ventilator. The stroke patient that skips her Plavix and she still smokes. That diabetic patient that sneaks candy into the ER and eats it while they're on an insulin drip. That 19-year-old alcoholic drinking a pint a day since the age of 15 on the verge of liver failure. All these patients, you can have that discussion about lifestyle changes, but it's up to them to want to make that change. We have resources in the ER to get the patient help, be it outpatient resources, inpatient resources, depending on the hospital, itself and their options. But patients have to want to help themselves as well. It goes both ways.
Keep your distance. I'm already in a bad mood.
I'm just getting some air.
Yeah, right. You're a terrible liar. Hope you're better at security.
Hey, now you're just being mean.
You realize that this is the second person to accuse you of that today. You starting to see a pattern?
No, but I'm starting to see why Gloria's unhappy with your patient satisfaction scores.
So the part of patient satisfaction that Pitt did not mention is what I already mentioned of what goes into the score itself. Management sees a number, but what they don't see is what the ER sees every single day.
When I was born at this hospital, I even volunteered here in high school. I was punched, kicked, spit at, pissed on, and feces thrown at me.
I talked to Gloria. I told her, listen, we got to do something to beef up security. This can't happen again.
It will. It will. Maybe not to me, but to somebody. The world's changed. People are angry. Our tempers are shorter, and we're still just trying to help.
You do help. You do make a difference. One asshole doesn't get to change that.
I think I'm done.